How did you become a dermatologist?
Interestingly, we're dealing with some young people. In fact, I mentored a UCLA student in a class of talking to retired people, freshmen talking to retired people. It's a new class. And I thought a great deal of how people choose their life work. A lot of people don't have any idea of what they want to do. They just go to school, they'll finish grad school, yeah. We had a loving, caring GP from Vienna who had immigrated to America in the 30s. He used to make house calls. He worked out of his house. And from age 4 or 5 or 6, when he made the house calls for chickenpox or measles, to look at me, I said, I want to become a doctor. That was proven with entry into college, medical school, internship, and the internship was over with out here in Los Angeles at LA County Hospital, which was the Ben Casey event of my life, working 36 hours straight without a break, et cetera, but so wonderful medically. And this was pre-Vietnam War, just beginning to get lit up. I was drafted as a doctor, went to Texas for training, was shipped to Korea, and worked in the biggest hospital in Korea. Luckily, because the medical experience was wonderful. Many other drafted young doctors were sent to clinics who saw colds in the morning and had nothing else to do after 10 o'clock in the morning. I was doing rounds at 7 in the morning and at 6 o'clock at night again, and all day and night, thinking about ill patients. Had 30 to 40 soldiers who had hepatitis in one ward and 30 to 40 other medical patients. 6 months into the tour, we had every ward. We had ear, nose, and throat, we had dermatology, we had radiology, every ward. It was the biggest hospital before they were evacuated back to America. 50,000 soldiers were in Korea at that time. The colonel came to me and said, we are not getting a replacement for the dermatologist, and his ward has anywhere between 5 and 20 patients every week. You're going to be the dermatologist. What? Yes. So the dermatologist, who I was friendly with, it was a small group of 30 doctors, so we all knew each other very well, taught me for a whole week all the variations of the kinds of things that young men get that I was going to be seeing. And I said, this is wonderful. I love internal medicine, but I really didn't like the lung. I was a little not so keen on kidney function. I loved infection, I loved immunology, I loved several other areas. Now I'm being exposed to psychiatric care, so much so, more infections, venereal diseases, surgery, which internal medicine doesn't have, on the skin. And I'm saying, this is wonderful. It's all of internal medicine, with infections, with immunology, with the lupuses, with the allergies, etc., plus all the things I just cited. I like this. And immediately changed my attitude about, after release from the Army a year later, I'm going to go into further my education in internal medicine. I applied to UCLA for the residency in dermatology. Very serendipitous. Thank you to the U.S. Army. Amazing. But this is, you got to have an open mind on life. And I have never been any less excited than I am right now at this moment. It's a wonderful field.
So then what happened? after UCLA?
The UCLA was 3 years. Got out in December of '69. Yeah. And the professor, Thomas Sternberg's friend, a man named Paul Levan, dermatologist in Beverly Hills, had a sudden heart attack in November or December of that year. And the professor asked me to see patients for him while he was recuperating. And I entered into that practice in January of '70 and continued working. He never came back to work. He was involved with some small area. In fact, something I became a little famous for also, he was injecting silicone into wrinkles, which was verboten, shifted and moved and created major problems. And I became the world expert in silicone injection problems. And I took over the practice, starting, I think, in '70, in the summertime, in Beverly Hills. And that was my world. Taught at UCLA, started a clinic at UCLA for allergy, because I always wanted to teach. Into this clinic came all of the red people, referred in for me to find the hidden allergen, for me to do testing on, to help them because they weren't making these patients better. Well, the story was always the same. Strange patterns on the face of red in front, white in the back if they're Caucasian, peculiar patterns on the body, never eczema like we saw in kids during the residency. You know, a little itch here, a little itch behind the knees, and it goes away. It went away. They burned out. These were strange, weird, unusual things. Well, the evaluations were really deep. Biopsies, patch testing, some blood testing, following, cessation of certain medications, more monitoring, and it came down to this was all because of the steroids. Steroids closes blood vessels down, and then they open up. So you get this redness, and then after a while, the redness doesn't subside. It stays wide open. The vessels stay wide open, and they're totally red, incapacitated, itching like crazy, burning like crazy, can't function. It was all because of the drug, which had come to the marketplace in '54. So already had been out 15 years or so. And we were already at the mid-strength ones, or even a little stronger, not the super potent ones yet. So we saw patients who had problems, but we could control them when we stopped the steroids. Then the super potent steroids came out in the late '60s, early '70s. And from then on, nothing but horrors, because they were all treated with the super potent steroids. The doctors aren't mean. They wanted to get everybody better fast. They didn't realize they were causing a major problem by giving the atomic bomb to everybody instantly. And started writing papers, started lecturing about this, and became embroiled with scores of patients because they were all over the world. Put up a website, wrote more papers, gave more lectures, etc., etc., etc. And it snowballed into a giant operation. I was doing routine dermatology with surgeries, etc., in the office, but at least 20–40% of the patients were steroid addicted, at least. And tried my very, very best to talk the rest of dermatology doctors into understanding that this had nothing to do with bad eczema, nothing to do with anything else other than the steroid, because into this arena, it wasn't just the eczema people, but about 5 to 10% had psoriasis, seborrhea, contact dermatitis, irritant dermatitis, winter itch, asteatotic eczema, et cetera, et cetera. So there were other diagnoses that looked exactly the same as the bad eczema people who were addicted to steroids. These other diagnoses were addicted to steroids also.
What was the pathway from you leaving the office of the former professor to you starting your own practice?
Oh no, I was still in the residency, and then residency is over, and I walked right into the office in Beverly Hills. Still, he owned it. It was his office. I probably took it over, bought him out 6 months later. But I was working for him on salary, because the intent was he was going to come back after he recuperated, and he decided not to just do the cosmetic thing.
Over time, did your patients evolve from being more traditional dermatology to more red skin? How did that evolution progress?
Well, I was practicing general dermatology with surgery, without surgery, allergy testing. I had probably tested 1,500, 2,000 patients with patch tests, because of all these red people and others. They were referred now to the office, not just to UCLA, mostly to the office. I was doing surgery, skin cancers, very little cosmetic stuff. I wrote about silicone problems. I wrote about problems with other filling substances, and I shied away from the cosmetic part of medicine, of dermatology. I was very interested only in the medical part. And a panoply of different diagnoses, again, from medicine to infections to allergy to surgery.
It's funny when you talk about, well, not funny, but it's curious when you talk about being in the Army and treating soldiers, and a patient now asking you if something is a fungus, and wondering in the back of your mind how much credibility you have with fungus diagnosis.
Oh yeah, and the non-dermatologist has a feeble education in dermatology, and often they'll hook onto a couple diagnoses, and that's all they remember. And they do remember fungus. That surely happens on the feet, between the toes, et cetera, et cetera. There are a couple other circular patterns. They surely know about hives. They surely know about drug eruptions. And they look at growths. But the strange, unusual, deep-seated infections, granulomas, internal related problems, sun problems, never passed across their mind. And it was fun. Now I was the expert in the community, in these arenas, and it's fun being an expert. And dermatology, which I didn't bring up with the Army, one of the fun things is, one of the problems with internal medicine was, the pain is here. Is it stomach? Is it lung? Is it heart? Could it be liver? I've got to do a lot of lab tests. I still can't, no matter how many questions I asked. In dermatology, you get a long history, you examine them from head to toe, and 90 to 95% of the time you can make the diagnosis. You don't need a laboratory. That was wonderful. That was real medicine, examination and history. So I love that part of it. Of course I ordered lab tests, but I didn't need it most of the time.
I think this is a great perspective in history for your viewers to really appreciate the evolution of really how you got to where you are today, and this crusade that you're on, and what the nexus and the basis of it was. So thank you very much.
No, you asked. I was getting very passionate in answering you, because I felt humble of being just a peon in entering into this field, and now supposedly somewhat famous because of this one diagnosis, but still fighting because it will not get recognized by the vast majority of doctors.
Well, I think your viewers are helping with the fight. So as always, please like, share, and subscribe.